Hello friends, welcome to the Pathology Insights. So today in this video we will be discussing about the clinical features, diagnosis and complications of infective endocarditis. In my previous video I have already discussed about the pathogenesis and morphological changes. In this video this is a continuation of the previous video. So coming to the clinical features, the most common symptoms with which the patient presents is first one is the fever. This will be high grade when it is present in the acute endocarditis, and it will be of the low grade in subacute endocarditis. Patient will also have the features like shortness of the breath, anorexia, weight loss, fatigue, arthralgia, myalgia, pleuritic chest pain, and the back pain. These are all the features with which the patient can present. And the signs in the patient, we have a splinter or subungual hemorrhages, rot spots in the eye, new changing heart murmurs, arrhythmias, pleural pericardial friction rub, Osler's nodes, and Janeway lesions. Now we'll see what are these rot spots, Osler's nodes, and the Janeway lesions. So signs, as I told you, we have a small petechial hemorrhages all over the body. Then the splinter hemorrhages or subungual hemorrhages means the hemorrhages will be present at the nail bed. And Janeway lesions, this means we have multiple hemorrhagic spots on the palms or on the soles. Now these are nothing but they are the small abscesses which are formed in the dermis, and epidermis is not involved in this, and these are formed because of the septic emboli which gets deposited in this area, and it has a bacteria, so we have a micro abscesses developing here, but these are not painful. Okay, Osler's nodes, these are the small nodules which are painful, and they appear at the tips of the fingers or the toes. Now these are formed by the deposition of immune complexes and as a result of hypersensitivity vasculitis. Now other changes in the heart and the respiratory system, the patient will develop the new heart murmurs, patient can have arrhythmias and pleural or the pericardial friction rub, and in the eyes, in the retina, when we see, we have the hemorrhages, which they call it as a rot spots. Now these hemorrhages, they are caused by again vasculitis, which is caused by immune complexes. So these hemorrhages, they appear flame shaped hemorrhages, and if you see, we have a pale center. Now this pale center is because of the deposition of the coagulated fibrin. So we have petechial hemorrhages, splinter hemorrhages, Janeway lesions, Osler's nodes, rot spots, and then in the heart we have murmurs, arrhythmias, and pleural pericardial friction rub. So that was about the symptoms and the signs. Now when we see the diagnostic criteria, it has been given by the modified Duke's criteria. Now in the modified Duke's criteria, we have pathologic criteria and clinical criteria, which is again divided into major and the minor criteria. The pathological criteria, in this we have two things, that is microorganisms demonstrated by the culture, and this culture is taken from either the vegetation or embolism from the vegetation or from the intracardiac abscess. So any material from these things which comes out to be positive on culture for the microorganisms, and another is if the histologically it is confirmed. We have the demonstration of these organisms in the vegetation or intracardiac abscess. So histopathological confirmation and microbiologic confirmation comes under pathologic criteria. Then clinical criteria, as I told you, we have major and minor criteria. So major criteria is there are three things in this. Blood culture comes out to be positive, and the culture taken is 12 hours apart. Both of the cultures should come positive for the characteristic organism or unusual organism. So two cultures we should take which are 12 hours apart. So both the cultures should come positive. Then development of the valvular regurgitation and ECG identification. ECG changes which are specific for valve related or implant related mass or abscess or partial separation of the artificial valves. And now these three are the major criteria. Then the minor criteria is the patient should have predisposing heart lesions, or he should have a history of intravenous drug usage. Patient should have the history of the fever and the vascular lesions. It can be anything like arterial petechiae, subungual splinter hemorrhages, emboli, infarct, septic infarcts, mycotic aneurysms, intracranial hemorrhages, and Janeway lesions. So all these are the vascular lesions. So anything will be taken as a vascular lesion. Then immunological phenomena like glomerulonephritis, Osler's nodes, Roth spots, and rheumatoid factor. And microbiological evidence is single culture will come out to be positive for an unusual organism. Major criteria is two cultures will come out to be positive 12 hours apart. The sample is taken, it comes out to be positive. Here minor is single culture is positive for the unusual organism. And ECG findings, it is consistent but not diagnostic of endocarditis, including worsening or changing of the pre-existing murmurs. So all this comes under the minor criteria. So this is what is the Duke's criteria, pathologic criteria, and the clinical criteria. In the pathological, we have microbiologic evidence and histological confirmation, whereas in the clinical criteria, we have major and the minor criteria. So the major criteria we have seen: blood culture positive, ECG findings, new valvular regurgitation. Minor, predisposing conditions, fever, vascular lesions, immunological lesions, microbiologic evidence, and ECG findings. So the definite diagnosis of infective endocarditis can be given when the patient has pathologic criteria and clinical criteria. In this clinical criteria, we should have two major criteria, or otherwise one major and three minor criteria, or five minor criteria. And there is a possibility of these features are of definitive infective endocarditis, and possibility of infective endocarditis is suggested when the patient has one major and one minor criteria, or the patient has the three minor criteria. So this is about the modified Duke's criteria. Then coming to the complications, we have cardiac complications and extracardiac complications. Cardiac complications are related to the valve injuries. So there can be valvular stenosis or insufficiency, valvular perforation, rupture, or aneurysms of the leaflets, or patient can develop ring abscess in the valve ring, or the myocardial abscesses, or suppurative pericarditis, and all these things can lead to further cardiac failure. So all these conditions come under cardiac complications. And extracardiac complications, they are mainly because of the emboli. So the emboli can enter into from the left heart, they can enter into the aorta and enter the systemic circulation, or from the right heart, they can enter into the pulmonary circulation and reach the lungs. So the consequences of this will cause complications. And then immunological phenomena which can cause further complications are glomerulonephritis, Osler's nodes, Roth spots, and synovitis. These are because of the immune complex depositions. Now, as I told you, because of the emboli which enters into the circulation, once it enters from the left heart, goes into the systemic circulation, it can affect many organs. So mainly kidneys are affected, and if the emboli goes and lodges in the kidney, the patient can develop petechial hemorrhages, which we call it as a flea-bitten kidney. Many small hemorrhages develop all over the surface of the kidney. So appears as if it is flea-bitten, hence it's called as flea-bitten kidney. There can be focal glomerulonephritis, or there can be infarctions, because these emboli can block the small blood vessels, causing infarctions. And when they enter into the spleen, the emboli, there can be infarction, there can be abscesses, or there can be hemorrhages. Similarly, in the brain also we can have abscesses, infarction, hemorrhages, and sometimes they develop the small mycotic aneurysms in the cerebral vessels. Further, the patient can develop the stroke and the meningitis also. And if the emboli enters into from the right heart, it enters into the pulmonary circulation, then the patient will develop hemorrhages and abscesses in the lung. So these are consequences of the emboli which enters into the circulation. So extracardiac, we have embolic consequences and immunological complications. So this is about the bacterial causes. Then we have infective endocarditis by other organisms also, like tuberculosis, syphilitic endocarditis, or fungal endocarditis, which can be caused by Candida, Histoplasma capsulatum, Aspergillus, mucor, blastomycosis, or cryptococcosis. And there can be rickettsial endocarditis also. So other than the normal streptococcus, we can have these organisms also causing endocarditis. Now that finishes the clinical features. To summarize the things, we have symptoms and the signs. So symptoms is what the patient presents with. There can be fever, shortness of breath, anorexia, weight loss and fatigue, arthralgia, myalgia, pleuritic chest pain and back pain. And signs is what the doctor sees in the patient: splinter hemorrhages, rod spots, new changing heart murmurs, arrhythmias, pleural pericardial friction rub, Osler's nodes and Janeway lesions. Then the criteria for the diagnosis, we call it as modified Duke's criteria. In that we have pathologic criteria and clinical criteria. Pathologic is microbiological evidence and histological confirmation. Clinical criteria, we have major and minor. Major, we have blood culture positive 12 hours apart, ECG findings and new regurgitations. Minor, we have predisposing conditions, heart lesions, then fever, vascular lesions, immunological lesions, microbiologic evidence, single culture positive, and ECG findings. So we give definitive diagnosis of infective endocarditis when the patient has pathologic criteria, and in the clinical criteria we have two major criterias, or if the patient has one major, three minor criterias, or five minor criterias, then only we give the definite diagnosis. When we see the complications, we have cardiac complications and extra cardiac complications. Cardiac complications are mostly related to the valvular lesions, so there can be valve stenosis, perforation, rupture, ring abscess formation, myocardial abscesses and suppurative pericarditis. Extracardiac is because most commonly because of the embolic phenomena. The emboli enters into the circulation, either into the systemic or into the pulmonary circulation, entering into different organs where they produces abscesses, infarction and hemorrhages. And another complications we have is because of the immunological mechanism, where we can have the deposition of the immune complexes causing the complications. So that finishes about the infective endocarditis. Thank you friends. Thank you for listening patiently.